Voilà, on a eu un peu de pub là.
Dr. Nasser, 5, 4, 3, 2, 1.
Good morning, good afternoon, good evening. It depends on where you are. Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 20 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. First of all, I would like to express my sincere appreciation to our distinguished speakers, Professor Kazadi Kalangu, Professor and Chairman at the Department of Neurosurgery, University of Zimbabwe. He is former President of the ANSA. He is former Second Vice President of the World Federation of Neurosurgical Societies, and he is Honorary President of the CANS. Professor Sanusi Samuila is Professor of Neurosurgery and Coordinator of the Niger Neurosurgery Residency Program, and he is Second Vice President of the CANS as well. Professor Dr. Ashraf Farid, Professor of Neurosurgery at Tanta University in Egypt, and one of the eminent skull-based neurosurgeons in Egypt. We also have Dr. Isini Ignatius from Cameroon. He is chairman of the Young African Neurosurgeons Committee in CANS, and he's a member in the Global Neurosurgery Committee in the World Federation of Neurosurgical Societies. As second vice president of the World Federation of Neurosurgical Societies, I understand that one of the most important missions of our organization is to promote educational activities among all young neurosurgeons, especially in African neurosurgical societies. I'm particularly pleased and humbled by the active role played by the CANS in the process of education and training. I would like to thank all our speakers. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. Now we start our symposium. I'm honored to be the moderator of this session. I don't know if Professor Mahmoud Khorashi, President of CANS, is available to say a welcome note or no. Mahmoud? Okay. I know that Mahmoud is in another webinar now about endoscopy. He is going to join us later. Now I invite Dr. Isini Ignatius to say introductory remarks.
Thank you so much, Professor Nasser. Okay, it's a great honor for me to be here today. And it is a webinar of the Egyptian, one of the pillars of African neurosurgery, Professor Kazadzi Kalangu, who does not need any introduction.
The sound is not good.
Ahmed, IT.
Hello?
Isini, we can hear you. Ahmed, we have technical problem. Okay.
Dr. Kazadi.
I think Professor Mahmoud Khorashi already joined the webinar until Ignatius fix the problem. Can we?
Dr. Kazadi. Dr. Kazadi?
Yes?
Try share your screen.
No, wait until
Okay.
Khorashi, I think he is joining. I can see that he joined the webinar already. Okay, he can't join. He's trying to connect. Ignatius, can you hear us? I think Dr. Ignatius has technical problem in internet. Okay. Now we proceed to Professor Kazadi.
It's okay. It's okay. I'm back.
Ignatius, are you online?
Yes. Sorry. There was some connection problem. So
Okay, no problem. We can start again. Now, Dr. Ignatius Sini is going to introduce Professor Kazadi Kalangu through a short biography.
Okay, sorry for the connection errors. So, as I was saying, Professor Kalangu is one of the pioneers of African neurosurgery. He's the chair of the Department of Neurosurgery in Harare, which is one of the training centers that has trained so many neurosurgeons in Africa. He is the past second vice president for WFNS. He's honorary president of the Continental Association of African Neurosurgical Society, honorary president of Association of Neurosurgical Societies of Africa, and he's a member of many international committees, especially the WFNS, WFNS. He has published so many papers and written so many books, but the most important, which is the essential practice of neurosurgery, which is dedicated for young neurosurgeons, written by more than 100 authors across the world. And amongst his many contributions to neurosurgery is a Harare, which has saved so many, the lives of so many children with hydrocephalus.
Sini, we can't see your screen. Would you share your screen again, please?
Yeah, I'm sharing. I don't know what is happening today.
You can stop it and share again from the beginning.
Are you able to see the screen?
Yes, your screen is shared.
Okay, well, sorry so much, yeah. Well, I have to do that again for the third time. Well, I'm never going to be tired to introduce my own mentor, Professor Kazadi Kalangu.
Okay.
As I said before, he is one of the pillars of African neurosurgery, the chair of the Department of Neurosurgery in Harare in Zimbabwe, the southern part of Africa. He's a former second vice president of the World Federation of Neurosurgical Society and the honorary president of the Continental Association of African Neurosurgical Societies and the Association of Neurosurgical Societies of Africa. He's a member of many international organizations, including the World Federation of Neurosurgical Societies. He is well published and has written so many books and book chapters, the most important of which is the reference book of the WFNS, the Essential Practice of Neurosurgery, which is recommended by WFNS for young neurosurgeons. And among the many innovations he is introduced into neurosurgery is a Harare, which has saved the life of many African children. It's a great honor for me to introduce him. And Professor Kalangu, you have the floor now for your presentation. Thank you.
Thank you very much.
Thank you, Sini, for this kind introduction. Now we are honored to listen to the presentation of Professor Kazadi Kalangu.
I think Professor Korashi is there. He just came in.
Maybe he joined us because Mahmoud.
Yep. Thank you very much. Thank you very much, Nasser, for organizing this. I think Ignatius has given a wonderful presentation, and Professor Kalangu and Professor Samuela Sanusi are well known to all of us. And we're very proud in Cannes to have our honorary president and second vice president join us in this webinar for young neurosurgeons across the continent and beyond. So without further ado, Professor Kalangu, please go ahead, Kazadi, my friend.
Thank you very much, Moody. Nice to see you.
Good to see you too, Kazadi.
Can you see my screen?
Yes, sir.
Okay. Thank you very much. It's a great honor to be invited to talk, particularly to young neurosurgeons and the young people who are actually our future. And it's very rewarding. And we are trying to share the little bit we know. And I'm going to talk today about parasagittal meningioma, the way we do this kind of operations in Zimbabwe, and our results and our difficulties and also our complications, so that we are, in order to tell our youngsters how to avoid them. It's the map of Africa.
Professor Kalangu, sorry, can you put it on slideshow to increase the size of your slides?
When we're trying to put it on a slideshow,
Okay.
the sound went away. I don't know why.
Okay, all right, it's okay.
That's why I've put it this way. Shall I try to put on slideshow and see?
Okay.
Let's give it a try, shall we? Okay. Let me give it a try and see. Okay.
Yeah, that's good.
You can still hear me, isn't it?
Yes, sir.
Good. So it's a map of Africa and okay. So from public been for is our school and the is fine.
Dr. Kazadi, your voice is not clear.
And me. Hello. Him. Hello, can you hear me?
Yeah.
Yes, we can hear you.
Okay. Let me share again because I think the sound went at one stage, isn't it?
Yes, yes, sir.
Yeah. Let me present it the way I was doing earlier on. It will work because when we did the trial, that's how it worked better. Okay. Good. Let me restart from here. That the definition that this is a lesion which fills the parasagittal angle, and there is no brain between the tissue between the tumor and the superior sagittal sinus. As you see here on this slide, you can see the tumor here, and the drawing here shows this very well. You see the sinus, and here you see now the meningioma, and then after the meningioma, then you start to see now the brain tissue. The incidence is about 17 to 20% of all intracranial meningiomas. And they are located either in the anterior portion, the third of the sagittal sinus, or in the middle of the sagittal sinus, or posterior. The majority of the tumors are found in the middle part of the sagittal sinus. Yeah, they can present a lot of challenge to be removed. That's what we're going to discuss, today, to see how we can minimize the problem and how technically it can be done. It's even more challenging when the sagittal sinus is invaded. This is a classification which was published by Professor Bonali and Professor Brocci. I've put it because they are the people who taught me neurosurgery. And as you can see, we have type 1, which is just touching the sinus. Type 2, porch sinus wall. Type 3, it invades the sinus, as you see here. Type 4, it invades the sinus and it compromises the flow. And type 5, you get the stenosis of the sinus. There is also another classification for Professor Sendou, which is very valid also. It goes up to type 6. The other parts, they are more or less the same, except when you see the way he describes type 2 and type 3. And then, of course, type 6, where the sinus is completely obstructed. And also part of the tumor is actually going beyond the sinus. Arterial supply for these lesions, it's very important to know that, because if you need to embolize or you need to coagulate and remove the tumor, you need to know that the supply is coming from the middle meningeal artery, the anterior cerebral artery, posterior cerebral artery. And then there are also venous drainage. They are particularly very important. We'll see later why they are very important. And they are key in the success of the operation. Basically, the venous drainage comes from pharyngeal veins to superior sagittal sinus, cortical veins, middle cerebral veins, lateral sinus, and scalp veins. The preoperative period, it's very good to do minimum a CT scan, possibly MRI. At least it will give you the location and the size of the tumor. After that, it's good to do angiography. Or if you don't have the angiography, you can use the MRI, and so that you see the artery which are supplying the tumor and the veins of drainage. But also most important is to know whether the sinus is permeable, is open or not, obstructed or not. And those tumors which are very vascular, you can see that there is like a tumor blush, which was called Madden-Low sign by a certain Smyrionotopoulos, because he says it comes early and stays late, like the Madden-Low. I'm sure he had a special Madden-Low. This is the number of patients we've treated in 12 years, and we had 31 males and 36 females. The age ranged between 31 and 62, the mean age being 42 years, and the tumor size varied from 6 to 12 centimeters. And the location of the majority of our tumors were actually in the middle, on the second third of the sinus. The clinical signs which we got when interrogating and talking to patients and asking questions were seizures, headaches, those are the majority. Then some had a motor or sensory deficit, some were confused, some had a swelling on the head, and generally patients came to us, minimum was 9 months, and most of the time it was 60 months, average being 18 months. Now, the reason why patients came to the hospital is because either they started to have a motor deficit, they started to be confused because they had a headache, they couldn't anymore treat with usual analgesics, and maybe a swelling on the head. Look, this patient had a swelling of the head here, and which he liked, and they left it like that. Then one day he decided now to get married. And he said, oh, for me to get married, I need actually to have a doctor to remove this. He thought it was maybe a lipoma or something like that. It ended up to be actually a meningioma. On the preoperative investigations, our patients had either CT scan, CT angiography, MRI or MRV or MRA. Few had cerebral angiography, and also there was an EEG because these patients, many of them came because they had the several seizures. Histologically, we're using the WHO criteria, and 80% of our patients were grade 1, means it's benign, and 15% had grade 2, and then 3% and 2% with various kind of lesions. But note that 3% had grade 3, and these were already malignant lesion. Besides the sinus invasion, we had patients in grade 1, 46 patients. Grade 2, we have 13 patients. Now in grade 3 and 4, we have 5 patients. And in grade 5, we had 3 patients. This is in general the operative technique we're using. We did a craniotomy over the tumor, which crossed the midline, so that you could work very well. We had the good space, and the instruments we used, we used the craniotome, of course, but I like also to use jiggly saw, particularly when I'm cutting the bone, which is on top of the sagittal sinus. so that we avoid, accident, because that's what the way I was taught, and I've kept that that habit to do that. With burr hole, of course, on each side of the sinus. Now, when we get into the tumor, the first thing we do is to gut the tumor from its center. I will go into detail later on. Then we remove the tumor from the brain and not the brain from the tumor by doing morbidity after the operation. And it's always good to have a magnifying device. It can be magnifying glasses, but it can be also a microscope. Then you coagulate the supplying vessels. We have used to minimize the blood loss. We have used the injection of hydrogen peroxide into the tumor, the parenchyma. And this was actually published by the late friend of ours, Professor De Souza, and it works wonderful and very well. Basically, we do the 4 Ds. You de-dress, you debulk, you devascularize, and then you dissect. This is what is done here. You follow basically the rule. You de-dress, okay? Then you debulk, okay? You devascularize around the tumor, and then you move the tumor to the center so that you remove it progressively without touching the brain. And then we avoid to make some complications, to make maybe some neurological deficit which were there to make them worse. For tumors which are in the anterior area, we do this kind of burr holes. This is classical, you know, we've seen that in all books. In the middle, this is how we do our burr holes, so that, and when they are posterior, this is the way we do our burr holes. It's very important that when you start to open the dura, you make sure that you don't injure the veins, because those veins, if you injure them, then you'll have really edema or venous infarct. So it's very important to preserve the veins. That's key. You see here, for example, you see there is a flap. There are veins that are going, you have to keep them straight. And this is the tumor which is in the middle there. Those veins, they are your friends. You keep them the way they are. They are always useful. You see here, sometimes you have to go and dissect the vein so that you remove it from the tumor. But when you are starting to operate this kind of tumors, don't do this kind of dissection. But if you have a magnifying device like a microscope, it's very easy to do that dissection. Now, what happens when you injure the vein? You can repair it, but this works only on the huge, big veins, not the small vein. The small veins, they get thrombosed when you repair them, but the big vein, if you repair them properly, they can still work. It is worthwhile. Now, you remove completely the tumor versus venous integrity. The answer is very clear. When there is a tumor which is near the vein, you better leave that little bit of tumor than sacrificing the vein, definitely. So the veins are more your friend than actually the tumor. This is one of the tumors removed, as you can see. This is the falx. The size of the sun is just on top here. Dura has been opened. The tumor is exposed, as you can see. Look here, the veins of drainage. In this case, the sinus was obstructed. So it's very important to save those veins, because if the patient has come to you alive, it's because he could still have these veins of drainage which was working. And here you see the tumor has been removed completely. Sinus management, if it is invaded, the first third of the sinus, that's not a problem. You can resect it without any problem. When you get on the second third, if there is a total occlusion, you can do the resection, but you have to make sure that there are veins of drainage which are present. If partially occluded, best protected. If one is not sure about what to do with that little bit of tumor which is into the sagittal sinus, you better leave it and remove the tumor and see whether there are other modalities like radiotherapy and so on, rather than trying to do something where you are not sure about and then complicate the situation. You can leave the portion of the tumor, and partial resection of the sinus can be done. This can be repaired. I will show you how we do it. See here, when we talk about type 1, this typical type 1 tumor. That's post-operative picture. You see here the sinus, which is very patent and clear. Here it's type 2, just to remind you. It's the patient that's got type 2 meningioma. And here you can see that there is a little bit of tumor there, and this could be removed without any problem. Now, when the tumor is invading the sinus like this is easy. You can actually remove the tumor and then repair the sinus. This can happen, and you can see here on this diagram how it is done. Now, when you get to type 4, you may repair the wall by getting a vein or getting a dura patch, something like that, and the repair. But in post-op, of course, this patient should be on aspirin, at least for 3 months, so that you don't get, clots. That's very important to remember. Or anticoagulant, if you have facilities to control the bleeding process. In type 4, usually the sinus is completely obstructed. And you'll see that the venous of drainage are so huge so that you cannot actually do worse than just removing completely the tumor and obstructing completely the sinus. But you have to make sure that actually the venous of drainage are intact. This is really theoretical. We did it several times, and it was sometimes a disaster because there were clots and so on, and it takes so long. I think usually if the patient comes to you with a completely obstructed sinus, sagittal sinus, it means this patient has developed other means and ways of doing the drainage. You see this patient, for example, the sinus is completely obstructed, but look the vein of drainage here. So this patient, you are safe. But when you do the operation, you must absolutely not touch those veins and keep them as they are. Keep them alive. They are your friends, and you'll avoid difficulties after the operation. Now, to control the hemorrhage, people have advocated endovascular embolization, the feeding vessels. I've seen some colleagues who are doing that, and they actually discourage me. They're saying there are so many complications that they didn't do it. You can, during the operation, cauterize the feeding vessels. That's standard. As I told you early on, we do also the injection of hydrogen peroxide. It's beautiful. You can see it works so well. And now, if the hemorrhage is out of control, it's better to remove the tumor in 2 stages. You just do your hemostasis, you stop the operation, and come the second time. Now, how do we know that there is excess of bleeding? I know people have used, and you've used before, to check the blood pressure, to check, the swabs, and to evaluate the blood loss. It has always been like an estimate. Between trial and errors, we found that the pulse is the best indicator. If you record the pulse when you start the operation, and while you are doing the operation, the pulse goes above 20% of the initial value, it's important just to stop and let the anesthetist to compensate, to put, a fluid or blood, whatever, until the pulse becomes normal, and then you continue. Because the moment the blood pressure starts to fall down, it means this patient has exhausted completely the mechanism of compensation. Mortality, we had 2 patients who died, one due to hemorrhage, the other one, it was a brain swelling, and the other one was the seizures, and the patient had aspiration of pneumonia. Morbidity, we had 9 patients, 5 subgaleal fluids, 4 brain swelling, which were sorted out with corticosteroid and mannitol and the duroplasty. We didn't replace the bone until the brain came down. The lesson we've learned is that the worsening of neurological examination, the worsening of neurological condition is usually transient. If you remove, and it was due initially when we were operating by removing the brain from the tumor. It means manipulating the brain rather than manipulating the tumor. The tumor, that's your enemy. That's the one you should manipulate. And also, we found that all malignant meningiomas, they recurred. We did 16 months, they were back. Total removal in Simpson 2 is really, you get really the cure. But you'll see that in some publications, they tell you even when you remove completely those tumors, after you wait a certain long period, like 25 years, you see that patients actually, some patients, they come back with the tumor again. The venous drainage must be respected at any cost. And the blood loss, as I told you, we use these hydrogen peroxide, which is very good. The brain swelling or possible brain swelling must be treated aggressively, mannitol and steroid, okay? And recurrence is associated with WHO grade, Simpson removal grade. And usually, the higher the grade, the higher the chance for the tumor to come back again. You see here, there's a publication. It is old, but I like it. Why? Because they follow the patient for 25 years, okay? And that was in Sweden. What they found is overall rate after 25 years was actually of recurrence with 47%. But at 10 years and 25 years, follow-up recurrence was 13% and 38% respectively in Simpson grade 1 and 2. At 10 years and 25 recurrence rate was 62 in Simpson 4. So you see, even though they did a good job, the patients, they still sort of have recurrence. Then there was a paper here written by my friend Tomazello, also followed that patient for quite a while, and showed that at 10 years of experience, of personal experience, he also reviewed the literature. He said, there is no evidence that aggressive management offers advantage in terms of recurrence. So these findings and the results of authors' analysis of the literature emphasize that the goal of radical tumor resection should be balanced by an awareness of the increased surgical risk attendant on aggressive management of sagittal sinus and bridging veins. So it's very important. What does it mean? It means you better leave that little tumor, which is near a big vein, you better save the vein, or if it is inside maybe the sinus itself, you better leave it. This is my conclusion. Preoperative MRV gives information on sinus patency occlusion, collateral channels and veins, and helps to plan better surgery. It's so important to have that. The preoperative MRV helps to prevent the cutting with the bone flap so that you can plan when to do the bone flap so that you don't cut really those veins. There might be also diploid veins draining into sagittal sinus. Of course, complete removal. I'm not advocating that we should remove completely the tumor. No, complete removal of the tumor is the goal. But one must always preserve the veins. Conclusion 2, when 1 or 2 sinus walls are invaded, be prepared to remove them and perform a venous graft. That's an easy, I think most of you have done microsurgery and into the laboratory. If you haven't, I think it's good to know that it's a very good tool for that. Another solution, of course, is removal of the mass only, the big tumor followed by a gamma knife or of the remaining piece of the tumor. Then to avoid huge post-operative neurological deficit, one should be able to repair bridging veins and collateral veins when necessary. When I talk the vein, those are big veins, not those small ones, because the success rate is very low. I checked also with other colleagues, they said also they didn't actually have success on that. When the sinus is totally occluded, it may be removed with the tumor without any grafting, only when you are sure that the collateral channels and veins are kept intact. Very important. Always check that. So thank you very much.
Thank you very much, Professor Kazadi, for this great presentation. And now we move to Dr. Isini. He is going to introduce Professor Samuela Sanusi, and then we open discussion among all panelists. Isini?
So much.
Can you share your screen, Ignatius?
Yes, the screen is shared.
Okay, thank you.
Okay. Thank you so much, Professor Nasser, for giving me this opportunity to present Professor Sanusi. Professor Sanusi is a teacher, a father, and it's a great mentor to many of us here in French-speaking Africa and the Africa continent as a whole. He's a professor of neurosurgery in Niamey, in Niger. And Niger is found in the West Africa. Aside the fact that he is the chair of the Department of Neurosurgery, the Faculty of Health Sciences in Niamey, he is in charge of the training program for neurosurgeons in Niger. And also he's also part of the team that is involved in the promotion of neurosurgeons in the university in French-speaking Africa. He's also the president of the ethics committee that controls the research activities in Niamey, and as well as being the president of the polio certification committee, which is very important public health problem in Africa. Professor Sanusi is the current president of the Association of Neurosurgical Societies of Africa and the current vice president of the Continental Association of African Neurosurgical Society. He's a great teacher and mentor, and he is well published. Go to PubMed, you're going to see a lot of his work that he has done in brain tumors, hydrocephalus, and endoscopy. Professor Sanusi, you have the floor.
Thank you. Thank you very
Thanks, Sini, very much for this kind introduction. Now we are very eager to listen to the talk of Professor Sanusi. He is going to give us experience among 25 years while operations of intracranial tumors in sub-Saharan Africa.
Thank you very much. Thank you, Nasser. Thank you, SNA. Thanks all of you for giving me this opportunity to share our little experience about management of brain tumors. I choose the example of Niger because the challenges are not the same between Niger and developed countries. To manage during microsurgical procedures. But we don't have we don't have molecular biology and some
I think there's technical problem in the voice. IT, please, Ahmed.
Dr. Sanusi. His connection is interrupted.
It is technical problem at Professor Sanusi internet.
Yes.
Okay, now we wait. Maybe he is going to fix the problem. Okay, now Kazadi, can you hear me? Kazadi? Ashraf, can you hear me? Professor Ashraf Farid? Ashraf?
I'm hearing you, Professor Nasser. Yes, I'm hearing you.
Okay.
I'm hearing you.
Would you like to? I think we can wait for some few minutes more, if it's not possible for Professor Sanusi to fix the technical problem. We can give him longer time, and you can make your presentation.
Okay.
Be ready.
Okay. Yes, sir. Do you see me now?
Yes.
Yes.
Not
okay.
yet, but you are trying to share the screen.
Now I have shared the screen.
I think now we can see. Yes.
Do you see me?
Unfortunately, we lost communication with Professor Samuel Sanusi, and until we get back to him again, we are going to listen to the presentation of Professor Ashraf Farid, Professor of Neurosurgery at Tanta University, and one of the eminent skull-based neurosurgeons in Egypt.
Bismillah ar-Rahman ar-Rahim. Very much for your kind invitation. Now I will speak about surgery of vestibular schwannomas, outcome analysis and experience in Tanta Neurosurgical Department. Let me to start by the definition of the cerebellomontane angle. The cerebellomontane angle is an angle located between the superior limb of the petrosal fissure and the inferior limb of the petrosal fissure, and this is actually the angle. And according to this angle, it harbors a very vital structures. Here, the trigeminal nerve as an upper complex, the facial and vestibulocochlear in the middle complex, and the lower cranial nervous in the lower complex with its important vascular structure like the ICA, BICA, and cerebellocerebellar artery. Our aim is a quality of life, to maximize the amount of neoplastic tissue to be removed, minimizing the morbidity and optimizing the quality of life. It is important to mention some anatomical landmarks. Here's the anatomy of the arachnoid, especially in the region of the internal acoustic canal. Here, when the vestibular schwannoma grow here, it will push this outer layer of the arachnoid, and when it grows up more and more in the cerebellopontine cistern, it has two layers of the arachnoid. This is very important during the removal as the policy of extra-arachnoidal, extra-capsular removal, which preserve the important cranial nerves, important vascular structure, especially the perforators. Here is the anatomical landmark of the facial nerve, and the facial nerve is not a constant anatomical structure. It has an anatomical variation, especially in larger sized acoustic neuromas, which could be splayed all over the capsule of the acoustic neuroma. It could be purely anterior, it could be purely posterior, it could be splayed out and distributed many fibers and fascicles all over the capsule of the tumor. Here is the different anatomical variation of the facial nerve along the capsule of the tumor. Here is the presentation of many fascicles and the posterior capsule, superomedial, inferomedial, and posterior capsule. It is completely posteriorly located facial nerve. And now to start with the practical session, the approaches of the cerebellomontane angle, the most commonly and the most popularly used approach with the retrosigmoid approach. Here is the our early experiences, right vestibular schwannoma and the supratentorial hydrocephalus. Here is the MRI, here is the preoperative MRI, and this is immediate postoperative MRI, and this is late immediate postoperative CT and 1 month postoperative MRI. The second case, large posterior, large right vestibular schwannoma. Here is the preoperative MRI, and here is the 4 years postoperative MRI and gamma knife radiosurgery. Another case, 5 years postoperative after gamma knife. Another example. This our early experience before the intraoperative monitoring and the facial preservation. With this approach, the incidence of facial preservation was so low, and here is the prognosis of the facial nerve after surgery. This is an example of a female lady with left vestibular schwannoma. Immediately postoperatively, she had House-Brackmann grade 1 total facial paralysis and improved by time to be now incomplete facial. This is 4 years after surgery and after physiotherapy, partial recovery of the nerve. And according to this result, in our institution, we were shifted to the intraoperative monitoring, aiming at the facial preservation. Here is our device. We started to apply the intraoperative monitoring of the nerve during all of our procedure now. This is the technical aspect. Preoperative view. This is the equipment, and we put electrode in the 3 main muscle group: orbicularis, oculi, and nasal muscles and oral muscles. And here the stimulating electrode. We start by stimulation of the posterior capsule in order to exclude the possibility of posterior location of the facial nerve or posterior location of the fibers. And here are the waves after stimulation and the action potential and stimulation of the nerve. And this is the train waves. In fact, the use of intraoperative neurostimulation confirmed the presence that the facial nerve may be splayed out into many fibers. For example, this case, stimulation of the nerve at the region of the internal acoustic canal resulted in 3 action potential. They add the orbicularis oculi and orbicularis oris and frontalis. And here is action potential on 1 muscle group. Here is an action potential on another muscle group. When stimulation of a part of the capsule, not at neither at the internal acoustic canal nor at the origin of the nerve. Now here is after using of the intraoperative neurophysiological monitoring. This is the preoperative MRI, and this is the 2 years postoperative MRI, and the complete preservation of the nerve, intact facial nerve function postoperatively, in spite of leaving a small part at the internal acoustic canal because of train activity, and we were aiming to preserve the facial nerve completely. This is after use of intraoperative monitoring, and this lady has complete facial function postoperatively. And this lady, we faced that the facial nerve is posteriorly located completely, and the stimulation of the posterior capsule resulted in action potential of all of muscle group. And in spite of that, we do intracapsular removal, and this is the postoperative complete preservation of the facial nerve function. And after gamma knife radiosurgery, there was evident central necrosis, but the patient's quality of life is intact facial nerve function completely. without any affection. This is another example. This lady, this is another example, pre-operative MRI and post-operative MRI, and this is the lady. Immediately after surgery, there is some weakness, but recovered completely after 2 weeks to be normal facial function completely. And of course, the aim of surgery to preserve this smile, being the quality of life. After 1 month, she is recovered completely to have normal, completely normal facial nerve function and no deficit at all. Another example, pre-operative and post-operative. The retrosigmoid approach, in spite of that, is not completely safe. There is complication of the retrosigmoid approach, and one of the most common complication of this approach is hematoma and cerebellar infarction. In fact, when revise the previous MRI we have presented, you will find a very big tumor, and the cerebellum completely covered the tumor. It is challenging to retract the cerebellar tissue to remove the tumor and to resect the capsule from the medial aspect and to do retraction on the middle cerebral peduncle and resultant ataxia. Also CSF leakage, hydrocephalus, difficulty in gait and coordination, dizziness and vertigo. These, the last two complications are commonly due to traction on the middle cerebellar peduncle. And this is an example of the complication. This is a big tumor, and after surgery, the patient developed hemorrhage. This is another case, a very big cystic tumor, and the patient also developed post-operative hydrocephalus and hemorrhage. So we have shifted to the translabyrinthine approach. We find some advantages and disadvantages. The translabyrinthine approach, we have recently begun to carry out in our institution because of some potential advantages. The translabyrinthine approach requires of the cerebellomontane angle than the retrosigmoid, because through the translabyrinthine approach, we did not retract the cerebellum at all, almostly according to the basic principles presented by Professor Kawazi. We go to the tumor from the front, not from behind. And we face the tumor directly, not indirectly. Minimizing traction of the, minimizing touching or traction on the normal brain tissue. So the indications of the translabyrinthine approach: acoustic neuromas in which hearing preservation is not aimed for, with poor preoperative hearing, and this approach could be used regardless of the size of the tumor. Acoustic neuromas with extracranial portion more than 1.5 centimeter in diameter. All of the cases, most of the patients with vestibular schwannomas presented with a very big tumor and hearing loss. The contraindication of the translabyrinthine approach are few, just only hearing ear, but this is a relative contraindication. This is not an absolute contraindication, because now in recent years the cochlear implant became more popular and easy to apply. So it is not no longer considered as an absolute contraindication. Otherwise, like otitis media, inflammatory conditions, and this is the first example of this very big tumor. Imagine with me how to retract this big part of the cerebellum to remove this tumor. And in fact, some surgeons which used to use the retrosigmoid approach advise to do routine excision of the lateral third of the cerebellum, even before starting of the surgery, as a routine step for exposure of this big part of the tumor. As a protocol, before translational approach, in our institution, we do CT of the vitreous bone thin slices to present the anatomy of the vitreous bone, which is variable from patient to another. Sometimes we can find a large pneumatization of the vitreous bone, and in another patient, we may find less pneumatization of the vitreous bone. The less pneumatization of the vitreous bone make it so difficult and so time consuming to excite for the step of labyrinthectomy, but the well pneumatized bone is so easy. Here is the pneumatization of the vitreous part of the temporal bone, and here is the labyrinth and the cochlea. Of course, the high jugular bulb is also a problem, but is not a contraindication for translabyrinthine approach. High jugular bulb will lessen the area of exposure, but not absolute contraindication. This is the post-operative MRI after 1 month after surgery. And now let me present video about the retrosigmoid and translabyrinthine approaches. Here is the example of the retrosigmoid approach. Here is the retrosigmoid approach. You see, Professor, the challenge of retraction of the cerebellum, that this step per se take a very long time, because we should deflate or to release CSF from the cisterna magna to get the cerebellum more lax. It needs some patient. Now arachnoidal dissection to release more and more CSF, and to getting the cerebellum is lax. One of the main problem of the retrosigmoid approach is unlax cerebellum, and so one of the tips and the tricks of the successful retrosigmoid approach without complication to get the cerebellum lax. This is a very big task and should take its time to achieve. And it should be, we should always take care for the vascular structure that adherent to the posterior capsule of the tumor. You should verify that these are not abnormal courses of the vascular structure. Here, after the retraction of cerebellum, we have surprised by a figure of 8 configuration of the posterior cerebellar artery. You see, this is the posterior capsule of the tumor, and we should at first separate the capsule to achieve the principle of extracapsular, extra-arachnoidal removal. Here is the separation of the capsule from the tumor. You see the big vessel that is adherent to the posterior capsule, and how can you dissect, how can you debulk the tumor except after dissection of this vessel? And to give you a way, the vessel is firmly attached to the capsule by a thick arachnoidal bands, and should be released first to separate this nerve, so to separate this vessel. You see? And of course, the use of intraoperative monitoring after this separation to stimulate and to verify that the facial nerve is not splayed into many fascicles along the posterior capsule. These are the disadvantages or the problems that we have faced after the classical retrosigmoid approach. You see this figure of 8 of the BICA, and effort was done to separate thoroughly without injury or spasm. It is not always a rosy way or paved way to excite the tumor with an ease, but with the tumor to reach this very huge size, the capsule become thick, the arachnoid become thick also, too thick to separate. That this is hardens the task for the surgery and lessen the time and lessen the steps of surgery. You see how different, how challenging to separate such vessels and keep it intact and not to preserve or to induce vasospasm. And the same time to preserve the facial nerve. You see, and to retract the cerebellum also, to expose the vessels and to dissect and to preserve and to separate. You see the vessel now after arachnoidal dissection over the posterior capsule of the tumor, the nerve, the vessel will be separated now. Cutting the arachnoidal bands, and it is allowable to coagulate the small branches that dipping inside the capsule of the tumor. It's not problem to coagulate and to dissect. Much better to avulse. The last piece. Now the vessel is completely separated now. So the next task is to complete the arachnoidal dissection over the capsule and do the ordinary steps. Separation of the vessel, further separation. Now, let me shift to the translabyrinthine approach. Here is the anatomy of the petrous bone from outside. Here is the incision. It is a classic retro incision, and this is the three-dimensional anatomy of the petrous bone from inside. Here is the cancellous part, three-dimensional, the cancellous part of the petrous bone to be drilled now. Here is the pneumatization of the petrous bone that we presented in the CT petrous bone. This is a pneumatized part, and inside this pneumatized part is the compact part, which is the labyrinthine apparatus and the canal surrounding the facial nerve and the bony canal surrounding the sigmoid sinus. Here is the drilling. Here is the pneumatized part. The pneumatized part. This drilling is in the pneumatized part like that. And this is the compact part, which is the labyrinthine apparatus, cochlear apparatus, and the sigmoid. This drilling is equivalent to that empty part. Here we will find the canal surround the facial nerve. This drilling is over the external auditory canal, and here is the tentorium attachment. Really time consuming, but when you see that you don't touch the cerebellum, you can tolerate, and we can be patient for this time consuming. Now the surgeon is drilling over the sigmoid sinus. And by the way, I would like to express my deepest gratitude and appreciation to our group of otolaryngology professors who share and join us in this surgery. Here is the sigmoid sinus, the compact bone covering the sigmoid sinus, and this is the cancellous bone, or the pyramidal air cells or petrous air cells. This empty part here, here. Now, the canal over the facial nerve, we use the neurostimulation to stimulate over. This is the sigmoid sinus, as you see, and this is the stimulation of the facial nerve monitoring all over the canal, the bony canal surround the facial nerve. Even it gives action potential even by lowest amplitude. 0.6 milliampere is sufficient to stimulate. And here is the labyrinth. Here is the labyrinthine system, and here is the dura started to appear, and this is the sigmoid sinus with a still surrounding eggshell of bone to be removed and exposed at the last stage of surgery before completing the transverse approach. We should keep this to the last step. We shouldn't expose the sigmoid sinus early to keep its environment. Now the dura starts to appear. Now the otolaryngologist will finish the pneumatization, and this is the labyrinth, this compact, the labyrinth or the semicircular canal. And here is the shell of bone covering the internal auditory meatus. And if we drill further, you see these are the labyrinthine system, and this is the labyrinthine system by the cadaver, Professor Albert Roton, and this is the sigmoid. This is the semicircular canal, and here is the pneumatization of the cells, and here is the jugular bulb. We are not need to drill here at all. It's not necessary to expose the jugular bulb because this is out of our area of exposure. And as we said before, the high jugular bulb is not a contraindication, but one of the disadvantages that this area of exposure will be lower than the normal anatomy of the jugular bulb. Now, the surgeon drill further over the sigmoid sinus. Here we use the diamond burr because of this critical, not to injure the sinus, diamond burr. Further drilling, you see these are the labyrinthine system. Here is the cochlear system, and here is the facial nerve, and this is the greater superficial petrosal nerve, and this is the genio, and this is the labyrinthine segment here. Now, here is the You see, this is the internal auditory canal drilling over the internal auditory canal. And one of the advantages of the translabyrinthine approach is early exposure of the internal auditory canal. This is not achieved through the retrosigmoid approach. Very important comparison, or a very important operative finding. We drill here first and we stimulate the facial nerve here first. And we could deal with this first. Here the laryngologist will separate the thin shell of bone. Here is the sigmoid sinus. This step should be done with caution, not to injure the sinus because it's so thin. And one of the possible disadvantage of the translabyrinthine approach is a time-consuming. This procedure will take a longer time than the retrosigmoid approach, and especially if there is inadequate pneumatization of the pyramidal or the petrous cells. Again, this is a sigmoid, this is a semicircular canal. Here is the internal auditory canal, and we will expose the intracanalular part of the tumor before seeing the tumor itself. Now we start labyrinthectomy. Here is the lateral and then posterior semicircular canal to be drilled. And the last step, we will remove this thin shell of bone. Now, you see here the extra intracanalular part of the tumor. We will stimulate facial monitoring at its origin. This is the extracanalular part of the tumor, and this is after removal of the bone. Here is the sigmoid sinus here, as you see. And we here at the origin, at the beginning of the extracanalular part. In comparison of the retrosigmoid approach, this step may be taken with some difficulty because the tumor is very big size. Here is the stimulation of the intracanalular part of the facial nerve, the retrolabyrinthine segment. In comparison to the retrosigmoid approach, the stimulation of the facial nerve may be difficult because the tumor is very huge size to reach. Now we will open the dura. We will take the neurosurgical procedure itself. Now the otolaryngologist finished and the neurosurgeon began to carry out the procedure. Now we open the dura, starting and expose both the intracanalular and the extracanalular part at the same time. Exposing the intracanalular and the extracanalular part at the same time. You see now. And one of the points, you see this part of the cerebellum, this very small part of the cerebellum that appear here. And this is the rest of the tumor covered by arachnoid. No retraction of the cerebellum is needed, or very, very minimal retraction, just a cotinoid patty, and this is the surface of the tumor. And now we dissect the arachnoid and carry out our procedure. Here is the post-operative after 1 month. Now I have finished my presentation, and my personal conclusion, going with the same basic principles. Functional outcome during vestibular schwannoma surgery is of great importance than pre-operative MRI and post-operative MRI with no residual tumor. We are aiming at the functional outcome and minimizing the complication, especially facial nerve preservation is a very big challenge. Also, cerebellar retraction is also a very big challenge. We observed that the recovery from anesthesia after translabyrinthine approach is much easier than after retrosigmoid approach, because the potential mild edema of the cerebellum after retraction for surgery for a long time. And so we will emphasize that the functional outcome should be taken in consideration before vestibular schwannoma surgery, not only vestibular schwannoma surgery, but brain surgery as a whole. And again, thank you for your attendance.
Thank you very much, Professor Ashraf Farid, for this excellent presentation. I'm really proud about the amount of complicated cases you are operating in Tanta University, and about this material and about the excellent results you were able to achieve. Now we are going to move, we will keep questions. We have many questions in the panel, at least 7 or 8 questions. We will also open a discussion among all the panels, but I think now it is time for Professor Samuel Sanusi to give his presentation and to give his experience about surgery of intracranial tumors in sub-Saharan Africa.
Thank you very much. So I hope that my presentation will continue, and hope that you will not have connection problems. Thank you, everybody. I'm going to share our experience on management of brain tumors. Before the disconnection, I show you our framework, and we have the necessary to perform that kind of surgery, but we have some problems on molecular biology and about some adjuvant treatment. And our patients come to consultation lately. In my country and in sub-Saharan country, considering this framework, we know that tumors are coming lately. So we see mostly large, expansive brain tumor, like you see in the screen. We are faced against 3 challenges. The first challenge is diagnostic challenges, because the limitation of histology diagnosis. And in the literature also, there is controversies on classifications. The second challenge is about surgical management. It's a long surgery, and it's surgery that the resuscitation means are necessary, and we have to pay attention, because this principle is mandatory. It is not brain surgery, it is tumor surgery. Surgeon must keep this policy during this surgery. The third challenge is about the prognosis. Without adjuvant therapies, and sometimes even with adjuvant therapies, the prognosis is poor. So for glial tumor, we know the result. Despite aggressive and standard management, the prognosis is poor. For example, for anaplastic astrocytomas, the prognostic is only 2 years. And for multiform glioma, it's lower than this moment. So the prognosis is very, very powerful, and all surgeons, I don't talk with about development country surgeons. Even for neurosurgeons working in developed country, it's a challenge. So in Niger, we have three situations. The first situation is when we have good prognosis, this surgery is necessary for our patient, and family patients and surgeon are very happy. The second is to consider an epidemiologic situation. We have risk error for diagnostic because we are in endemic part for tuberculosis. And the second situation is complex and sometimes more severely complex situation. About good prognostic surgery. During the last 20 years, we surgically managed 83 cases of pilocytic astrocytoma, low-grade astrocytoma, low-grade glioma, and third cases of papillomas. We can see here example of good prognostic surgery. When the surgery, when we remove all the tumor, we know that we will have good prognosis. And another good situation here, before the operation, after the operation, the prognosis is good. And here also, even the large tumor, the prognosis is good because it's low-grade astrocytoma. And for intraventricular papillomas, we use microsurgical techniques combined with the endoscopic. The endoscopic is helpful because it's show us where is the adhesion of the tumor to make the devascularization for the tumor easily, because we know where to go to remove the tumor without big hemorrhage. The second situation is our endemic area. We are living in endemic area of tuberculosis. And the problem is, for this tumor, for example, we can say that we can do biopsy before surgery, but we know that the brain tuberculosis can seem astrocytomas. For example, here we went for a presumptive glioma tumor, but after the surgery and histology, it's not glial tumor, but tuberculoma. And even here in intraventricular tumor, we went for subependymoastrocytoma, but the histology is not subependymoastrocytoma. It was a tuberculosis. And in this case also, nodular tumor in the fourth ventricle. After surgery, we discovered that it was not an ependymoma, but it was an tuberculomas. And here also, it's not easy to know if it's ependymoma. If it's a tuberculoma, we go for surgery and we discover that it was meningiomas. And here is a typical case. Everybody can say it's astrocytoma, but after removal of the surgery and histological diagnosis, it is it was also tuberculoma. And another example here, because you can have abscess in brainstem, this patient have biologic signs of chronic infection. We went for abscess, but it was not abscess, it was diffuse brainstem glioma. After this good situation, that's this risk of error situation, we mostly faced against complex situation during the management of brain tumor. For example, here we have a brainstem glioma, diffuse brainstem glioma. Our only arm is to perform endoscopy, but we don't know. We know that this endoscopy is not sufficient. Another example here, because of late consultation, we have this large tumor. We do not retain the indication for surgery for this patient because we know that surgery will not make this patient going better. Going for surgery, the problem is sometimes I ask myself if it's not an ethic problem going for surgery without radiotherapy for malignant glial tumor. For example, here we have a large tumor. We decided after consultation of the family of patient, we decided to go for the surgery. We make a large gross total resection, and the prognostic was very, very good because we have, without adjuvant therapy, because it's astrocytoma grade 2, we have good prognostic for this patient during the 3rd years after the surgery. That means that if the surgery is complete, if the removal is complete, we can make the patient going better for 2 or 3 years. For example, this example, after the surgery, we have good prognostic. But sometimes it's not easy because for anaplastic astrocytoma, even when we perform large surgery, the prognostic is not good. The patient is good for 6 months, but not more than 6 months, and the situation complicated after this period. Another example here, we can perform all we can do to do the best the best you can give to make it a good surgery, but it's not sufficient. You have to conduct adjuvant therapy for this kind of patient. Another example, ependymoma and medulloblastoma, we continue making the surgery, large surgery, and sometimes we can have 1 or 2 years good prognostic for the patient. So after this complicated situations, sometimes we have special complex situations because surgery is a challenge. We don't know exactly what is the histology of the tumor, and we are faced to the family and to the team to decided to go to surgery when the situation show us is high-grade glioma. These are 3 examples. The first example is this one, this large tumor. We perform, this is a patient before the surgery. We perform surgery. The patient is after the first day after this surgery, because we applicate the principle of it's not brain tumor, it's only tumor surgery. It's not brain surgery, it's tumor surgery. The situation is good early, but after the patient, the recurrence come, and the patient is not going good after 2 or 3 years. This patient early follow-up is good. Everybody is happy, but we know that the tumor, the recurrence is there without adjuvant therapy. Second situation, special complex situation, we went for surgery the first time. The surgery, the removal was not completed, and the recurrence of tumor, we went for the second operation, and after this, the patient continued, the tumor continued to progress, and this is very disappointed situation for a surgeon, for the team, and for the family also. This another example for large tumor, we perform a large gross totally removal of the tumor. The 5 years follow-up of this child without no adjuvant therapy is very, very good. But we know that it can, the recurrence is there. This patient can go in. This tumor will regrowth or not. We think that in the literature, many times the tumor regrows. Another example for malignant astrocytoma, we perform gross total resection, early follow-up, everything okay. For this patient, we have 3 years follow-up without recurrence of the tumor. So what to say for conclusion? I think that for malignant glial tumor, going for surgery with or without adjuvant therapy remain a daily challenge. Multidisciplinary management is mandatory, and also interchange with the family is mandatory to help the surgeon to don't be alone face against this tumor. Thank you very much for your attention.
Thank you very much, Professor Sanusi, for this great presentation. And now we will answer questions we have in the panel and then proceed to open discussion. We have Professor, if we have question to Professor Kazadi. Kazadi, are you here?
Yes, I'm here.
Okay, the first question, how to differentiate parafalcine from parasagittal meningioma radiologically?
Parafalcine
and parasagittal.
Okay, it's very simple. Is that if there is brain tissue in between, then you know that it's parafalcine. But if there is no brain tissue in between, then you know that it is parasagittal.
Okay.
That's why at the beginning of the definition, I defined it that way. If it's not that way, it's not a parasagittal sinus, meningioma.
And so you suggest to make such differentiation, of course, in the MRI?
Yes, you can see it. You can see the normal tissue between the sagittal sinus. If you see the normal tissue between the sinus and the tumor, then you know that it is parafalcine.
Okay. Another question, if there is bone involvement, do we remove the bone flap? And if you remove the bone flap, when do you like to perform cranioplasty?
with the bone flap, I will see how the brain is relaxed. If the brain is not swelling, then you can do cranioplasty immediately after that. But usually I leave it alone because sometimes you think that the brain is relaxed, but 24 hours later, the brain might swell. You never know. So sometimes I leave it like that and then put the cranioplasty after a couple of weeks, minimum.
Okay, another question for Professor Kazadi. What are the minimal tools a young neurosurgeon would require in order to perform meningioma surgery in low source resetting?
Okay.
That's a good question, I think.
Yes, a very good question. A very good question. And I think for young people, they should know that before we had the ultrasound aspirator like CUSA, and before we had the craniotome, electrical craniotome, we were doing those operations with jiggly saw, doing a burr hole with Hudson brace, and we did it very well. And how did we actually dissect the tumor? We were using this diatomy loop, and which we're using to go and gut the tumor in the middle, and then progressively make them hemostasis, cauterize the vessels, feeding vessels, and removing the tumor progressively. So we can actually, with minimal but yet necessary instruments, do the operation. Of course, if you have, ultrasound aspirator like Cavitron, CUSA, it's much easier. It makes life much easier. Okay.
Thank you. And I have a question for Professor Ashraf Farid. Did you perform ventriculoperitoneal shunt before cerebellopontine angle schwannoma surgery?
Yes, thank you for this important question. It is so important. It is advisable to do ventriculoperitoneal shunt prior to vestibular schwannoma surgery because necessary due to large tumor obstructing the CSF pathway. We may find a very small tumor and hydrocephalus. So, with a differentiation or apart from other posterior fossa lesion, it is advantageous to do preoperative ventricular shunt before vestibular schwannoma surgery. This have many advantages. It facilitates the exposure and help lax the cerebellum, and also minimize the effect of the cerebellar edema that obstruct the CSF pathway. So preoperative hydrocephalus is better than postoperative. Preoperative VB shunt is better and more advantageous than postoperative shunt, because postoperative shunt in many cases is in the acute setting, not in chronic setting. In chronic setting due to adhesion and post-irradiation, but safer to do preoperative shunt if there is large hydrocephalus and advanced papilledema. It is safer to do preoperative than postoperative.
Thank you, Ashraf. Another question. Do you suggest doing partial resection with radiosurgery in such operations?
Yes, thank you. If there is healing, if there is facial nerve preservation, yes, I am with this strategy. If there is facial preservation, because this is a benign tumor and the rate of growth is few millimeters per year. So my aim is maximizing the amount of tissue removed and the preservation of function. Preservation of function and the quality of life is much, much important than total removal and complete facial, especially in a benign tumor.
Okay, we actually have many questions, and most of these questions are very interesting. Another question, when do you like to use translabyrinthine approach for better resection, probably in order not to leave any compression over the brainstem?
Again, question?
when do you like to use translabyrinthine approach while operating in these cases? If it offers you better resection in order to not to leave any compression over the brainstem, do you think so?
Yes, yes. Regarding the translabyrinthine approach, it may enable better resection because there is no cerebral retraction at all, and the area of exposure is equal the translabyrinthine and retrosigmoid. But if we focus on the cerebral retraction, it deserves to be focused upon. The translabyrinthine approach gives the same area of exposure, and we can change the operating table many times to see the depths. And if there is something compressing the brainstem or adherent to the brainstem or adherent to the big vessels, it not differ with the translabyrinthine and the retrosigmoid. But the problem of cerebral retraction is deserved to be highlighted upon. So the may be equal in the translab and retrosigmoid. The problem is adherence to the brainstem, and the manipulation is so dangerous, and also adherent to big vessels supplying the brainstem, like the neurovascular complex.
Okay. Another question, Ashraf, what about opening of the internal auditory canal in retrosigmoid approach?
Opening of the internal auditory canal in the retrosigmoid approach is also feasible and done by many surgeons, but it is a late step and late identification of the facial nerve. Also, the section around the internal auditory canal is so risky in the retrosigmoid approach. The advantage of the translabyrinthine approach is that the opening of the internal acoustic canal is done before exposure of the tumor, and there is early identification of the facial nerve in comparison to the retrosigmoid. In the retrosigmoid approach, when you retract the cerebellum, you will see a very, very big tumor, and you cannot see neither the internal auditory canal nor the beginning of the facial nerve. While in the translabyrinthine approach, you will see the facial nerve before seeing the tumor. So the structure to be early identified is better to preserve than the structure to be late identified.
Another question, Ashraf. Ashraf, you are taking most of the questions because I can see that more questions are coming. And so now we have another question. Does loss of hearing justify a subtotal resection in your point, from your point of view?
Subtotal resection and radiosurgery is associated with facial preservation, not hearing preservation.
And because now we have, okay, go ahead.
Manipulation and the extra manipulation of this area carries a risk, and it is a well-known fact that the most vulnerable portion of the facial nerve is here at the entrance of the internal acoustic canal.
The last question. While doing ventriculoperitoneal shunt before tumor surgery, did you have any positive cytology for cerebrospinal fluid which corresponds with histopathology of the tumor?
No.
You never asked for this?
No.
Okay. Now we open a discussion. We are honored to have Professor Hisham Basyouni from Germany, and he is going to start to open discussion among all the panels. Hisham, please go ahead.
Yeah, good Friday. Thank you very much for these very interesting presentations, and thank you also for giving me, as a European guy or Egyptian origin, an insight into sub-Saharan neurosurgery. Very interesting, because we do not see these, usually we do not see these large tumors, and for me it was interesting, and it was actually also very painful to see this, because it is somehow frustrating to see these cases, and you're not who are coming late with very progressive diseases, and actually young children which could have been saved in better conditions. But you are doing a great job, so thank you very much for this. Well, Dr. Ashraf, in regard to retrosigmoid and transpetrosis or posterior transpetrous approach or translabyrinthine approach, I'm not doing the posterior transpetrous approach which you have shown. It is very time consuming. That's one point. If you are doing it, and I've done it several times, it takes a long time, even if you have got practice in doing it. And as I understood, your ENT colleague is doing it, this step. The second, it's I'm doing it in a retrosigmoid manner with a retrosigmoid craniotomy, small craniotomy, even for large tumors. And I think it's very important to release CSF and to be patient. You have to be very patient, and then you have got, even in large tumors, you've got a relaxed situation, not in the first moment. The first moment the cerebellum comes out, but you have to be very patient. And I do not use any retractors anymore. I've used in the early times, but I'm not using retractors anymore, even in very large tumors. So the retrosigmoid route is a very good one, and I think it's also the most common for these tumors, as far as I know, not only in Germany but worldwide. In regard to because one of the question was a decompression or opening of the internal auditory meatus. It is, of course, in large tumors, you do not, as you said it, you do not see it. So, but in medium and small tumors, it is an early, not a late step. You are opening, you're opening it in order to identify the facial, and in trying to hearing preservation surgery, which is of course a disadvantage in the transpetrous or translabyrinthine approach. But you have cases where they have got useful hearing, serviceable hearing, and of course you are at least trying to, will not be in every case that you preserve the hearing, but you can try, and you will succeed in several cases. So this is, of course, one of the disadvantages, and also in the retrosigmoid approach, you can nicely identify, using also intraoperative neuromonitoring, of course, all the neural structure, the facial nerve, cochlear nerve. You can identify and using stimulating probe the facial nerve. So I think this is not in the retrosigmoid approach. It's very useful and good. There was one question about the ventricular peritoneal shunt. Actually, I have never put in a VP shunt pre-op, even in large tumors, even in tumors grade 4A, 4B of the Hanover classification, which are actually compressing the fourth ventricle and where you've got hydrocephalus. And as you said, you can even have got hydrocephalus in smaller tumors, which is rare occurrence, but it can happen. I even do not put or try not to put in and external ventricular drainage because of I would be afraid of upward herniation in these large tumors. So in these cases, I'm trying to release CSF during surgery. And if you've got an hydrocephalus afterwards, which rarely occurs, then you can put a VP shunt. This is the way I'm doing it, and as far as I'm overseeing it, most of the colleagues, at least in Germany, are doing it. So yeah, that's in regard to the Dr. Sanusi about the parasagittal meningiomas. I would be a bit reluctant because you said that the anterior 1/3 of the superior sagittal sinus, you can take it or you can occlude it. Usually nothing happens, and usually it's a sort of safe procedure, but you can be unlucky, and not only you but the patient also that you get. I'm sorry, it was not Dr. Sanusi, it was Dr. Kasadi. I'm sorry, because if you can get venous infarction. So it is not a safe procedure, and you should try to preserve it. You can take the superior sagittal sinus if it is completely occluded by the tumor, and of course while also preserving the peripheral draining veins. So I'm doing it that in an incomplete occluded sinus, I'm not doing a sinus graft action. If the sinus is not completely occluded, I leave tumor and I'm doing a follow-up. I'm not doing radiosurgery or any sort of radiation therapy. Of course, we're not talking about malignant meningioma. Then, of course, there's a clear indication of doing radiosurgery or radiation therapy. But in the normal case, I'm following it up, and usually the tumor will by itself occlude the superior sagittal sinus during some years of follow-up, and then you can take it safely and do a complete resection. So in the first case, of course, this needs a follow-up of the patient, which I do in every meningioma case over the years, non-stop. But this is my policy in dealing with these tumors. So thank you very much.
Thank you, Professor Hisham. I think Professor Hisham has raised a lot of important issues, and one of these issues, when he says that he never insert ventriculoperitoneal shunt even in large tumors. In such context, I would like to hear the opinion of Professor Sanusi and then opinion of Professor Ashraf.
Thank you very much. I'm happy to share my experience on brain tumors. I would like to make a comment about Professor Ashraf on the choice of translabyrinthine approach. Do you advise neurosurgeon to perform the approach, or you advise neurosurgeon to make only the neurosurgery time? Because in our country we are going to give courage to the neurosurgeon to learn how to make the translabyrinthine approach and also to remove the tumor. What do you think for this, to include it in the curricula of neurosurgeons?
Ashraf?
Second question again, please.
Do you advise to include for neurosurgeons, for residents, for the curricula for residents to include the approach, translaborantin approach, not for ENT, for neurosurgeons?
Yes, why not? Why not? Another alternative approach to the retrosigmoid approach, and it has some advantages over the retrosigmoid approach. So it is deserved to be taught by to the neurosurgeon. Really, I have attended many workshops regarding the translaborantin approach in my country, and this part is carried by the otolaryngologist. Because it is difficult to the neurosurgeon to carry the post tasks. So يعني the energy will be يعني the energy will be wasted for such approach. So, but it is good for the neurosurgeon to have an idea and to be oriented by the anatomy and the vascular structures and the microanatomical variation with the translaborantin approach, but not to carry the procedure by himself, the otolaryngologist.
What about the question of Ashraf? What about the professor question of Professor Hisham Basyouni from Germany? He was asking you why you are doing the ventriculoperitoneal shunts. Yes. In Germany, usually they don't insert shunts, yes, even in huge lesions.
Thanks, Professor Hisham, for your important question. Really, in our early experience, we were using the ventriculoperitoneal shunt prior to surgery, but now seldomly used, except if the patient may come at night with manifestation with his intracranial pressure and the MRI showing the transmandibular permeation, and it is difficult to prepare for a major surgery. So we insert the ventriculoperitoneal shunt as to relieve his symptoms until definitive surgery, but seldomly used now. But 20 years ago, we was using this, but now seldomly used, except in some emergency cases.
Okay, I think we have already Professor. Go ahead, please, Ashraf.
Now, as I presented on my video, we insert lumbar drain and release CSF because laxing the cerebellum. This is the routine work we nowadays.
Okay, now I'm honored to introduce. Oh, okay, I'm honored to introduce Professor Osama El-Ghandour. He is honorary president of the Egyptian Society of Neurosurgery and former dean of the Faculty of Medicine at Azhar University. Professor Osama, are you here?
Yes, I am. Yes, I am. Well, I thank you very much indeed. I enjoyed all the lecture indeed. But I just have a few comments about the parasagittal meningioma from our African colleague. That in parasagittal meninge, you know that the highest incidence or the potential malignancy is there. So recurrence is always there. Sometimes at least in 5 to 10%, they may come back, whatever the surgeon's smart or skill. And if the tumor is occluding the sinus, there is no problem. You cut it, you take it, no problem. But sometimes the tumor is just touching the sinus and it's open. All you do is just put a dural graft and you don't really make a hassle. But the most important point about the parasagittal meningioma, it's not the sinus. It is protecting and preserving the superficial superior cerebral veins.
Yes.
Because even you do a marvelous surgery and 2 days later the patient becomes plegic simply because of thrombosis. So we learned over the years to give anticoagulants starting from the second day, even the sinus is intact, even the superficial veins are intact. And we are very careful during dissection and trying to protect every vein around the artery. This is very, very important indeed. And the matter is always there. is preserving and protecting these superficial cerebral veins and starting anticoagulant as early as possible. I have a little comment about the our friend Professor Ashraf about the CPA. I mean, whatever the size of the hydrocele, so long the patient has no neck stiffness, we don't need to do a shunt. And sometimes some patients with CPA or any mass in substitute fossa presenting with marked rise pressure and neck stiffness, I tried for a couple or several days of marked dehydration and steroids. And when it's more responsive, I would do shunt surgery. And luckily enough, all of them, they respond. So we don't do shunt surgery at all in pre-operative. But having said that, after surgery, some of them, they do need shunt surgery, probably from the junk, from the residue, from the debris of surgery. Sometimes basal adhesions happen. And I remember a funny case. After it did a very good surgery, the patient has C. rhinorrhea. And we discovered that he has hydrocephalus. So we said probably he has opened mastoid cells and wasn't very well sealed during the surgery. So we sealed that very simply, but there's no improvement. And we had to put a shunt. So shunting post-operatively sometimes is mandatory to relieve the hydrocephalus or to relieve the C. rhinorrhea. I know C. rhinorrhea is very rare to happen after posterior fossa surgery, but it does happen indeed if you do a lot of surgeries like that. Thank you very much, Professor Nasser.
Thank you, Professor Osama. I think Professor Osama was raising 2 points. The first one about parasagittal meningiomas, and the second about the cerebellopotine angle lesions. And we listen now to Professor Kazadi if he wants to make a comment about what Professor Osama has just said.
Sure. Thank you very much, Professor Sama, for your beautiful comment. As you heard, I insisted a lot on the preservation of the veins. In fact, that was the major progress in this type of surgery. So I agree entirely with you. I really emphasize that particular point. I was also going to make a small comment on Professor El-Sham from Germany regarding the cutting of the first third. Okay, of course, we don't cut it, we cut it only when it's been completely occluded by the tumor. And of course, the same rule applies to make sure that we preserve the veins, okay, even anteriorly. Doesn't mean that when you cut that part of the sinus, you actually sever the veins as well. No. We have to keep the vein intact. That's the key for successful operation. Thank you.
Oh.
Hisham, do you want to say anything?
No, I agree. Because one of your slides was a bit, one could misunderstand it because I think in the first line it was the anterior 1/3 you can close. Of course, any part of the superior sagittal sinus, if it is completely occluded, then there has been already a drainage which has been installed during the time
yes.
Compensating for this, so you can remove it and not if it's the first or the second or the third of the sinus. So this is a lucky situation.
And this can be known from angiography. If we do pre-op angiography, we can recognize if the sinus is totally occluded. In such case, it's easier, or it may be more appropriate to cut it.
And angiography, I'm sorry. Angiography is of course the best method, but it's invasive. So we are actually doing the MR venogram, And you can see it also not even in the venogram, which is I think less important, but you can, if you follow the superior sagittal sinus on the triplanar MRI, and you see the coronal cuts, the sagittal cuts, then you can see if it is completely occluded, especially in the coronal cuts. Follow them, then you can see if it is completely occluded and which walls of the sinus are involved by the tumor. I think this is the best method and non-invasive method.
Yes, Hisham, when I speak about angiography, I mean any type of angiography, maybe magnetic resonance angiography as well. But I just need to know, by the way, what's the accuracy of MR venography in showing if the sinus included? Can you rely on this investigation 100%?
I personally, I would not rely on it, actually, because often you find that it looks occluded, but it's still patent. So, so I would not rely on MR, and even on the best quality. Often you get not the best quality, so it's even worse. But I would not rely on it.
Okay, Ashraf.
Yes. I would like to welcome Professor Osama. I would like to add a small comment. CSF rhinorrhea after retrosigmoid approach we have saw in only one case, but resolved completely. This is associated with the degree of pneumatization of the mastoid. In retrosigmoid approach, we do mastoidectomy until we find a part of the sigmoid sinus. In some cases, you will find the sigmoid, a large part of the sigmoid of the mastoid bone covering the sinus. So you remove a large amount of the mastoid air cells. In such cases, we should plug well with muscle graft or muscle graft to plug these air cells well to lessen the complication of CSF rhinorrhea. As a basic principle, CSF leaked after posterior fossa surgery always associated with high tension. So shunt, as Professor Osama said, will solve the problem. But how to minimize if there is a big amount of mastoid bone to be removed? We should plug with muscle fibers, plug very well. In comparison with the translabyrinthine approach, the otolaryngologist closed this large amount of pneumatized and plugged very well all these potential risks of CSF rhinorrhea. And cases of translabyrinthine approach, we didn't face CSF rhinorrhea. So
thank you.
In fact, in fact, when we found a lot of large mastoid air cells, we take the bone, we took it from the nibbling, and we put it back. Then we seal it over it with the bone wax. I didn't really put muscles, but the best thing if you wanted to put fat, but usually it's very well sealed. It's very rare. I was surprised. In fact, I left my first assistant to do it, so he wasn't really very keen to seal it very well, and discovered that lately. So we learn from complications that we have. If we see large mastoid cells, use the bone, don't throw it away. This nibbled bone, put it back and put over it bone wax to seal it.
Yes,
okay,
sir.
Thank you.
Completely correct. Yes, sir.
Thank you. Any other comments or questions from the panels or from the attendees? I'm happy that Professor Mahmoud Khorashi, President of CANS, is able to join us again. Actually, he is contributing to 2 webinars at the same time, our webinar and the Neuro Endoscopy webinar of the World Federation. And thank you, Mahmoud, for joining us and for contributing to our webinar and for giving us such honor. And do you like to make any comments or say any notes before I close the webinar?
Thank you very much, Nasser. Really, the standard of webinars has really been, the bar has been raised consistently, and it's thanks to all your efforts in selecting the wonderful panelists and speakers from across the globe, and really our societies and members of our young trainees in Cannes are really benefiting from your initiative. I'd also take this opportunity to thank Professor Kalangu Kazadi and Professor Sanusi, and always a pleasure to have Ignatius there as well. And I miss whenever Professor El-Ghandour is not present or not Mawjood, I miss him. So it's always nice to see my Southampton colleague.
I always enjoy having you, dear friend, my dear successor.
Thank you. Thank you so much.
Pleasure.
Thank you very much. I think it is the time to close the webinar. It was very successful webinar. We had very, very excellent discussion among all the panels. We had a lot of questions from all attendees. It was very, very promotive, really, webinar about oncology. And we had different experiences from Egypt and from Zimbabwe and from Sub-Saharan Africa. At the end of this webinar, I would like to thank all our speakers, Professor Kazadi Kalangu from Zimbabwe, Professor Sanusi Samuila from Niger, Professor Ashraf Farid from Egypt, from Tanta University. I would like to thank Professor of Cancer, Professor Mahmoud Khorashi. I would like to thank two of my friends who are always contributing to the panels each Friday, Professor Hisham Basyouni from Germany and Professor Osama El-Ghandour. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, especially at such a difficult time of COVID-19 pandemic, sharing your knowledge and experience with young neurosurgeons and with African neurosurgeons is really highly appreciated. Thanks to all of you. Thanks to Utopia Pharma and eHotline. And thanks for IT people who are supporting me in all webinars since the beginning of this series. Next Friday, we have another webinar about endoscopy in the treatment of hydrocephalus with Professor Kolkarni and Professor Alberto De Letala, Professor of Manze. And I will be speaker in next Friday too. Thanks to all of you and see you again.
Thank you very much.
Thank you very much.
Keep safe.
Organizing that.
Thank you very much.
See you all.